Hi. So we'll speak about this one very important lecture called as pulmonary emboli or pulmonary embolism. Now the point is that this chapter is something that is associated with DVT as well. So the most common cause of pulmonary embolism is a DVT, and DVT is nothing but a deep vein thrombosis. A deep vein thrombosis is a thrombosis that develops in the lower limbs. It develops in the lower limbs, and which part of the lower limbs actually it develops in the mostly it develops in the veins like popliteal vein. It develops in the iliac vein. It develops in the femoral vein, which is the most common vein that it develops into. It develops into the popliteal vein, Okay, and the reason I'm writing all of this in red is because this is such a fatal condition, and it has a very high mortality rate in case it goes undetected. So it is from the popliteal vein, it goes into the femoral vein, and then it goes into the iliac vein, and then from the pelvis it also goes into the via the IVCs, it goes into the pulmonary veins and so on and so forth. So that's from IVC, obviously in the right atrium, right ventricle, and then in the pulmonary artery. Sorry, my mistake. Into the pulmonary artery to finally dislodge. Okay. So what are the risk factors for pulmonary embolism? Now, the first risk factor that I can think of is the DVT. Okay, DVT is a very important risk factor, deep vein thrombosis. And what is the risk factor for deep vein thrombosis? Could be a lot of genetic factors. It could be a lot of genetic factors. Okay, so there are patients who come to us with factor 5 factor 5 laden mutation. Okay, and what happens is that in this condition, the factor 5, that's factor 5 of the coagulation cascade, is something that is inactivated by a lot of compounds, inactivated by antithrombin, thrombospondin, etc. So this does not happen. So it's mutated, and what happens is that this is overactive. So overactivation of factor 5 occurs in factor 5 laden mutation. Okay, so it can be due to factor 5, it can be due to antithrombin 3, it can be due to antithrombin 3 mutation, where antithrombin 3 is not actually functioning to inhibit the coagulation cascade. So antithrombin 3 mutation. And then it can also be due to protein C, protein S deficiency. Protein C, protein S deficiency. And protein C and protein S are very important proteins that are secreted by the liver, and they keep the coagulation cascade again in check. So that's very important. Also, it can be due to some OCPs, it can be due to certain OCPs, it can be due to pregnancy. It can be due to pregnancy, it can be due to an adenocarcinoma, which adenocarcinoma, usually an adenocarcinoma of the small intestine, of the large intestine, like polyps, can lead to a lot of excess coagulation. Adenocarcinoma is very important. Also, a lot of surgical procedures can lead to this condition. Surgeries can lead to the pulmonary edema. Also, we have that renal conditions like membranous nephropathy. Membranous nephropathy causes antithrombin 3 loss. So what can be a clinical vignette? A clinical vignette can be that there is a patient who has already been diagnosed with probably membranous nephropathy, but what happens is that this patient comes and there's a lot of dyspnea, there's a lot of difficulty in breathing, there is hypotension, etc. So you have to think on these lines. Okay, now also there can be a lot of chronic myoproliferative disorders, myeloproliferative disorders. So what happens is that there is a lot of thrombus or a lot of hematological proliferation that can occur. So because of that, there can be excess of coagulation. That's one. Apart from that, I do not think we've missed out on any very important causes. Let me just tell you that there is something called as a virtue triad. There's something called as a virtue triad. And the virtue triad is something that is depending upon three things. It's a triad that depends upon the first is depending upon the endothelial damage. So the endothelial damage is one of them. Also depends upon the hypercoagulability. Hypercoagulability is something that is again associated with like something that we spoke about, factor 5 laden mutation, antithrombin 3 deficiency, or protein C, protein S deficiency. Or it could be an endothelial damage. Let's say if there's an endothelial damage like a collagen defect, probably something like a muffin or any other disorder, Ehlers-Danlos to be more specific, collagen defect, and muffin is an elastin defect. And it could also be due to stasis of the blood, and stasis of the blood can be due to a lot of conditions, like probably let's say it is due to pooling of the blood, it's due to certain amount of hypotension, it's due to probably the cardiac failure, congestive cardiac failure, stasis, due to a lot of causes. So this is basically the virtue triad. That's the only thing that's usually asked when it comes to DVT. But now we are getting into the PTE of it. All right, that PTE as in the pulmonary thromboembolism that we already started with the chapter. Okay, and in pulmonary thromboembolism, what I need to, because this is such an important disease, the fact is that there are three divisions that we've made a severe, we've made a sub-severe or submassive, okay, submassive, and then we've made a non-massive or a non-massive, okay, non-massive, non-severe. Okay, so when I'm starting with the severe one or the massive one, so the massive one, massive, okay, pardon my handwriting, but this is because I'm speaking, I think it's very clear what I'm trying to convey, right? So there's severe and massive, and then when we speak about massive, what actually occurs is that there is a pulmonary thromboembolism. The thromboembolism of 50% greater, that is blocking the lumen, and because it's blocking the lumen, okay, there is going to be decrease return to the left atrium, and if there's going to be decrease return to the left atrium, that means decrease to the left ventricle. Blood flow to the left atrium, left ventricle is decreased, okay, first of all. Second, there's going to be right ventricular pooling of blood, right ventricular pooling. So what's going to happen is that there's going to be very importantly, very importantly, there's going to be shift of septum. Okay, that's again very important. And there's going to be right ventricular dilation. Okay, there's also going to be hypotension. There's going to be shock because of hypotension, and then there's going to be a syncope. So I want you to understand this, okay? There's less blood coming to the left ventricle, okay? There's less blood coming to the left ventricle, there's less output, decreased cardiac output. Because of that, there's going to be a syncope, number one. Second, there's increased blood in the right ventricle, because here the entire pathway is blocked, okay? Here the pathway is blocked. So let's think of this as a pathway. My bad. So this pathway that we have here from the right ventricle to the left ventricle is blocked, and because of this block in the pathway, there's going to be increase in the blood in the right ventricle, and because of that, there's going to be dilation of the right ventricle. Correct? There's going to be dilation of the right ventricle. All right, and there's also going to be a very important thing, that there's going to be septum deflection or septum pushing towards the left, and that can be seen on the echocardiography also. All right, and that's very important. And also I want you to understand a very important fact is that there's also going to be decrease in the PaO2. The alveolar O2 is going to be perfectly fine, and that is one thing. And therefore the PA minus A gradient, this AA gradient, alveolar artery gradient, is going to be increased, okay? That's very important. Secondly is that it's going to be a type 1 respiratory failure. It's going to be a type 1 respiratory failure where the CO2 diffusion is normal. Why is the CO2 diffusion normal? Because the blood vessels, okay, the blood vessels that are present, okay, the CO2 has a very high diffusion capacity. So CO2 has a very high diffusion capacity, and because of its high diffusion capacity, it does not need a lot of capillary transit that should occur for the CO2 to diffuse. So this is going to be a type 1 respiratory failure. If it would be an increase in CO2 as well, the CO2 would not be normal. So then it would be a type 2 respiratory defect where there's going to be hypoxia and hypercapnia. But right now in pulmonary PTE, pulmonary thromboembolism, we see a type 1 respiratory failure. Where there's only hypoxia. Very important to understand this as well. Now coming to the next part, which is the submassive, and let me write submassive in yellow color, okay? Submassive in yellow, submassive PT. What happens in submassive PT is that you're going to have a little bit of myocardial necrosis of the right ventricle, because the right ventricle plus right ventricular failure, you're going to have right ventricular failure, but luckily no left ventricular failure, so no hypotension. All right, so no hypotension. Luckily this is pretty okay, but the right ventricular hypokinesia is definitely seen because of the right ventricular necrosis. And at the same time, because right ventricular necrosis is seen, obviously I expect you to understand that there is going to be certain amount of troponin 2, troponin I, troponin T to be elevated, and troponin I and troponin T is going to be elevated obviously because of the myocardial necrosis. Also at the same time, because of right ventricular pooling, there's going to be a lot of ventricular pooling, right? There's going to be a lot of ventricular pooling that's going to occur, as we have seen in the last diagram, that there's going to be right ventricular pooling, and because this is blocked, there's a block here, so right ventricular pooling is going to occur. And this right ventricular pooling, what does it cause? Right ventricular pooling is going to cause increase in the BNP. Why is there going to be increase in BNP, brain natriuretic peptide? I hope you understand that there is a mechanism where the body, if there is increase in body fluids, then the BNP in the body increases. The BNP increases to a very high extent. So if there's increase in body fluid, if there's increase in body fluid in the right ventricle, then there's going to be increase in BNP, and that's a very important fact which we can use for diagnosis of right ventricular heart failure. Okay, so there's going to be right ventricular failure as well. There's going to be right ventricular dysfunction. And now finally we are coming to the non-massive or the non-massive PTE. The non-massive PTE is nothing. It's just no RV dysfunction, no hypotension, okay, and no myocardial necrosis. Okay, there's no myocardial necrosis. So what is the problem? The problem is dyspnea. There's going to be a clear lung. You're also going to have certain amount of hemoptysis in case. Okay, hemoptysis, if there's a certain amount of damage, there's going to be hemoptysis seen as well. So that's about the 3 types of clinical features that we have in pulmonary thromboembolism. How do you want to diagnose it? Coming to the very important part. Let's say you suspect a patient of this. You want to use the golden 4 diagnostic tools. First, you want to do a clinical. You want to check clinically if he has a hypertension or not. You check the BP. You check for the BP if the BP is high, or if it's normal, or it's low. Okay, if it's high, you want to rule out any of these causes. If it's low, you want to think in terms of your severe PT. If it's normal, it could be a submassive or a non-severe PT. Okay, second, you want to check for any lung defects or any lung symptoms like a dyspnea. Okay, you want to check for that as well. You also want to do echocardiography to check for your right ventricular dilation. You want to also check for your septum deviation that I've already spoken about because of the pooling of the blood in the right ventricle. And also you want to check for biomarkers. You want to check for biomarkers like troponin, TROP-T. You want to check for TROP-T. You want to check for TROP-I, which can suggest myocardial necrosis. You want to check for BNP if BNP is elevated. You also want to check for D-dimer levels. Why do you want to check for D-dimer levels? Just in case if there's a pulmonary emboli, the D-dimers are going to be highly elevated, or if there's a DVT, D-dimers are going to be highly elevated. Also, I want you to do a little bit of imaging. You could do a little bit of imaging to see for CT. You could do a CT angiography. Where you can directly check via invasive radiography. Okay, and the markers, as I told you, you have BNP, TROP-T, TROP-I, and that's about it, and D-dimers. So now let's talk about what do we do to rule out from AMI. Okay, so obviously a certain amount of symptoms when you see clinically: dyspnea, difficulty in breathing, a little bit of chest pain, a little bit of fatigue is also seen with AMI. To rule out AMI, you want to do an echocardiography. You want to do echocardiography. Also, you want to do an ECG. You want to do an ECG to rule out AMI. Okay. Also, you want to rule out an arrhythmia. So you want to do you want to do an ECG for the same. Okay. You can also do an X-ray. Okay, but in X-ray, what you can see in X-ray is that you can see atelectasis, that is collapse of the lungs in the lower part of the lobe. But that is again something that's not very specific, and that's why you cannot rely definitely on that. Okay, and certain things that I want you to understand is that if you want how we do the management, there's something that we need to really understand is the management of a patient. So if it's a submassive, non-massive, or whatever, whichever type of PT, in all types of PTA, you want to go for an anticoagulant, and the anticoagulant of side, you want to go for unfractionated heparin, or you want to go for low molecular weight heparin. Which one do you prefer? You obviously prefer the low molecular weight heparin because it has lesser side effects. But let me tell you that unfractionated heparin is easier to control. Compared to a low molecular weight heparin. Also, you want to overlap it with warfarin. You could overlap it with warfarin, and you want to check for an INR. You want to keep an INR around 2 to 3. If your target INR is going to increase, okay, your PT time is going to increase. INR is equal to PT, and that's how I look at it. So if your PT is going to increase, then you want to keep a check on your warfarin levels as well. Okay, fine, that's fair. Now, second is that what else can you do if anticoagulation is contraindicated? Let's say if there is a PT with a large clot, then you want to go for a thrombolysis. Thrombolysis is going to be again if it's a high risk patient, and if it's a low risk patient. If it's a high risk patient, that means that the patient is really severe. So you want to do a catheter. Okay, you want to go via the catheter, and you want to literally break the entire thrombus. Or if it's a low risk patient, okay, if it's a low risk patient, you want to go for an antiplase. Antiplase is going to completely cause thrombolysis, and it's going to get rid of the thrombus in a submassive case. Okay, but if it's a massive case, obviously you want to go for catheter. Apart from that, I think we've covered most of the PT types. We've covered the PT diagnosis. We've also covered the PT treatment. I think that is about it. This is one of the most important disorders that we have. The only thing I really want you to understand is that on X-rays, we can see something called as line. We can see something called as long linear bands of atelectasis in the lower lobes, as I've already mentioned out here. Atelectasis in the lower lobes. And I think we have done. Also, a very important score is being used to categorize the PTE. Well scored, there's something called as a high probability, there's a low probability. A well score is used to classify these cases into high probability and low probability. And a highly probable case of getting into a PTT, into a severe PTT, is when you have a helical CT pulmonary angiogram, and the angiogram is showing a positive, pulmonary angiogram positive. But a low probability is when you're D-dimer, okay, if you're just in D-dimer, and if you have a greater than 500 level, so then you want to go for a PT, pulmonary angiogram, CTPA, sorry, CTPA, computed topography, pulmonary angiography. Okay, then you want to go for that. Apart from that, I'm pretty sure most of the stuff we've covered. Let's say for instance, you have a clot. Okay, you have a clot. There's going to be line of Zans. Line of Zans is something that are seen on the clot, on the emboli. And the emboli, okay, when you do a biopsy and after the treatment, let's say the patient has passed away, okay, and when you do the emboli and when you look for the emboli, okay, what you see is you see lines of Zan. So that's something that's again asked, so that's why I wanted to cover this lines of Zan. These are lines of Zans that are formed because of, it could be due to platelets. This is platelets and fibrin, plus fibrin, and the RBCs, okay, and the RBCs that are present in the middle. So it's platelet, RBCs, platelet, fibrin, RBCs, platelet, fibrin, RBCs. So that's something that's going to help us understand that it's going to be a thrombi that's present, okay. And again, it can be also very important. Some other rare instances, there's going to be a fat emboli. There's something called as a fat emboli. Fat emboli is when it's associated with fractures. Let's say you've got a fracture, and the fracture, okay, and the fat from the bone marrow of the fracture leaks, and it goes to the lungs and can cause as PTE, pulmonary emboli, not thrombo, but pulmonary emboli, fat pulmonary emboli. Okay, they can also be a very important neurological symptoms because of the emboli reaching the CNS. So there can be a CNS neurological symptoms. Also, if this fat reaches the other parts of the skin, you can be a lot of petechial rashes that is present, okay. Also, there's something called as an air emboli. Now, air emboli is something seen as a very important disease called as Caisson's disease, or decompression sickness, okay. Decompression sickness. What happens is that, let's say if you're a diver and you're diving really low at certain meters below the sea level, okay, and you suddenly ascend, and when you suddenly ascend, the nitrogen in your body, okay, the nitrogen bubbles, precipitate. Let's not get into the physics of it, but the point is that there is a lot of nitrogen that was at a high pressure, and when you suddenly go up, there's going to be at a low pressure, and because of that, the bubbles are formed in the blood, okay. The nitrogen bubbles are formed in the blood, and what happens is that this blood has a lot of bubbles, and this bubbles can actually go to the lung, and it can cause your pulmonary emboli again. So how do you want to treat it? You want to treat it with hyperbaric. You just want to treat it with hyperbaric oxygen, and you're going to remove it. And there's a very important last type of pulmonary embolism that's rare again. A rare type of pulmonary embolism is called amniotic fluid emboli. And amniotic fluid emboli is something that can lead to DIC. It can lead to disseminated intravascular coagulation. What happens is the amniotic fluid, because of the bleeding, can also be introduced into the fetal vasculature, and because of that can lead to disseminated intravascular coagulation, and because of that a lot of platelets are formed, and the RBCs that come, they form a lot of schistocytes, and they form schistocytes, something like this. They form schistocytes, and when they form schistocytes, these DICs are formed, which break the RBCs, and they can also cause a lot of pulmonary embolism, okay. That's another very important cause.